I like the acronym BUBBLE, BUBBLE. Have you guys heard that before used? BUBBLE. So it's breasts, uterus, bladder, bowels, lochia or bleeding, and then the E is episiotomy, but obviously we know now it's usually a laceration, but it spells better if you use the E, episiotomy. So a good way to think about how you're going to go about doing a head to toe assessment. So breasts, what are we looking for with breasts?
Lumps, tenderness.
For postpartum specific?
Oh, yeah. Oh, just kidding.
Yes.
Breast milk.
Yes. So is our milk coming in? Are we starting to see that leaking of the colostrum? While they're in the hospital, they may start to fill, but they probably aren't going to have the engorgement in the hospital when your milk fully comes in and it's like a rock hard feeling.
So annoying.
Yes, but it's something we want to educate our patients about before they go home. And part of that is we want to make sure that we're preventing mastitis. So how are we going to prevent mastitis?
Massage it.
We can, if we start to feel like we're getting like a clogged duct, we can massage it. What else is going?
Is it eat?
Hmm?
Eat?
Yes, frequent feedings. So how often should our breastfeeding babies eat?
Every 3 to 4 hours.
2 to 3 for
2 to
breast. 3 to 4 for formula.
Okay.
So we're frequent feedings. What else?
Heat pack? No?
You can do heat packs if you're getting that clogged duct too, but alternating which breast you start with, so that we're getting equal stimulation on both sides. Because they usually do a better feeding on the first breast than they do on the second breast. The second breast is more like kind of a snack sometimes. So making sure we're alternating. So you'll see people say like a clothespin or a safety pin, whichever side. Now there's an app for that, right? There's an app for everything that will tell you which side you started with and how long they're feeding. The other big thing is making sure that they're breaking suction by putting the finger in the mouth and pressing down on the tongue. Because if we're pulling the baby off, then we're getting that cracked and bleeding nipples. That open sore is gonna be a sore spore infection. The other thing I like to talk about with patients is making sure that we're feeding in a like dark, quiet room at night versus a bright room during the day. So we're helping them switch between nights and days. Okay, so then uterus. What are we checking for with the uterus?
How hard? Soft
Yep,
it is.
so we're gonna make sure that it's firm. You'll also hear the term for soft, boggy. We do not want to see a boggy uterus. So we're checking that it's firm. What else?
Shrinking.
Yep,
Oh,
so
it's
it's going down. We're making sure that it's what we call midline. So if we're deviating to the right or the left and we're starting to see the uterus, the top of the uterus increasing, like where the spot is, so we want it kind of at the umbilicus at delivery. If it starts to get like +1, +2, we're getting fingertips is how the -1, the +1 that you guys have heard, I'm sure, is fingertips from the umbilicus. So if we're starting to get 2 fingertips above the uterus and off to the side, what are we thinking might be happening? Any ideas? there's usually two causes of our uterus displacing. One is a full bladder. Full bladder, bad for bleeding. So full bladder, so maybe we're getting close to that 2-hour recovery period. Mom's legs are starting to come back. We're gonna go to the bathroom. We're gonna see if we can empty that bladder. Completely normal to chart, like +1 and off to the right or left when we're getting towards the end of our recovery before they pee. But I like to tell my patients, every time you nurse baby, you should be getting up to the bathroom and voiding each time.
Okay.
So we don't wanna go long periods of time, because then our bladder gets over distended and then we don't get that sensation that it's full, and we're more likely to have a hemorrhage. The other reason it might get distended is we have clots in the uterus that we need to expel. So unfortunately, that means one of the labor nurses gets to go in there and really press on the belly hard. It is not a fun job to have. The other day, I have black cloud. No black cloud on the floor. Anybody will tell you. Lindsay, black cloud. So we had a hemorrhage, of course, when I was charged Saturday. Not this last Saturday, but the one before that. And yeah, post C-section, starting to get feeling back, hemorrhage. Had over 1,000 out. So in like 15 minutes. Like when they bleed, it's fast and it's a lot.
That's scary.
Yes. So I got to be one of the ones that pressed on it. Because and you guys will talk about when we get to postpartum hemorrhage later, one person, their only job is to massage that fundus, because that is one of the ways we make sure that it gets firm if we start out boggy. So we check in to make sure that we're getting firm uterus, that it's not distended, that we're not deviated off from the midline. So firm midline at the U is our typical charting. So that brings us to the B for bladder. Like I said, making sure that we're emptying our bladder every 2 to 3 hours. If we have a bunch of urine retained, we're at risk for a UTI. UTIs are, I don't want to say common, but can happen more often during pregnancy and then that immediate postpartum, especially if they had an indwelling Foley catheter. For whatever reason, C-section, or you should be seeing on the floor that they're straight cathing their patients every 2 hours. If they are putting an indwelling catheter in, that is not following our protocol.
My nurse did that today.
Yep. Yes, they still do it. Somebody asked me the other day, Lindsay, when you have a patient who's first time mom, they get an epidural at 3 centimeters and we know it's gonna be a long time, do you just put an indwelling in? I said, no.
Nope.
I straight cath them twice, and if they need more than that, then I put an indwelling, because that is our protocol.
Yeah, she had a continuous PCA for her epidural, and so she just told her, like, it's up to you, but I can put a catheter in you, blah, blah, and so she did
that. Is old school. That's what we used to do on everybody. We used to put Foley catheters. Everybody who had an epidural got an indwelling catheter in. It stayed in. We actually ended up pushing with them initially, and you did not take it out until the baby was ready to deliver. And we know that that is super bad on their urethra, because you're pushing that Foley balloon out with the head. So we're causing all kinds of trauma that we didn't know we were causing, right? We don't think about these things.
Oh my gosh.
So when I started 11 years ago, downtown, that was what we did. So it's probably been within the last 5 years that we stopped doing indwelling automatically. There are still physicians that have the strong belief that you should put an indwelling in everybody, because it keeps the bladder drained continuously. So the bladder acts like a big balloon in baby's head, in the way of baby's head distending. So it makes sense. You keep it drained, it's not in the way, baby's head will descend easier, but we're more likely to cause that UTI to happen. So people think, oh, you're straight cathing, you're constantly introducing bacteria. But actually, if you think about
It's supposed to be
all
sterile anyways.
all that's going on when you are laboring, there's the
It's
fluid,
already-
the
yep.
blood, all that just travels right up that indwelling catheter, causing a UTI. Obviously, we don't have a choice when they're post C-section, right? Because they had surgery, they can't get up for at least 6 to 8 hours of like getting up easily. So you have a catheter in them, but just the importance of keeping everything clean as much as you can for those section patients. They're not gonna have nearly the bleeding that
One of the other
vaginal.
girls too, she said that they didn't take out a catheter. Like the lady delivered last night at like 6 p.m. They
Mhm.
didn't take out her catheter till this morning. Like
For a C-section, yeah, it used to be 24 hours
Oh wow.
that we used, like if they were the
Yeah,
morning
yeah, yeah.
C-section, like the 7:15, we used to leave it in
Until the next morning.
all night because it's easier
Mhm.
for the patient
Mhm.
when they're in pain to just go to sleep at night and not have to worry about getting up and up and up. In the last couple of years, we're like,
Gotta get up.
we need to get it out as soon as possible so we don't cause those UTIs. So that's our bladder, making sure it's empty, making sure it stays empty. Paying close attention to whether your patient is voiding a large amount, because if they're just peeing just a tiny bit, eventually that bladder's gonna get so over full that we're gonna have to do a straight cath. And if you're getting a straight cath on your patient and you're getting over 1,000 out, you're leaving and indwelling in, and they can actually go home with a catheter because of issues
Oh wow.
with getting over distended. So super important for those postpartum nurses to watch that the rest of their hospital stay. Okay, bowel. We know that it's gonna be a little bit more challenging for them to have a bowel movement. For a long time, we've been doing stool softeners to help with that. Kind of firm stool. You don't see it as much anymore that they automatically order it, but it's a good idea for them to take a stool softener a couple times a day just to make sure that when they do have to go, it's easier for them to go and they're not having to strain. The last thing you want to do with stitches is strain to have a bowel movement. But big, making sure that they're drinking a lot so that that's not getting super firm. They're getting up and moving after delivery. Lochia, we're looking at the amount. We do not want them saturating more than a pad in an hour. Obviously, we don't want them to have lots of clots. Anything more than like a golf ball size, we're gonna say, okay, is this what's going on here? Normal, if they've been laying down for a long period of time, stand up, it's normal to have a gush, normal to have a clot. That blood's been sitting in there, but we don't want it to be odorous. We don't want it to be like a yellow color, because what could that signify? Infection. So uterine infection is called endometritis. Which is an infection in the endometrial lining. So that would be a odorous yellow color fluid. And then E, making sure that our tear is not looking red, or I like the acronym REEDA, R-E-E-D-A, when you're looking at the tear or the episiotomy. So redness, edema, ecchymosis, drainage, and approximation. Making sure that those stitches are lined up, that we are approximated, we are not having that foul smelling drainage, we're not super swollen or red. All signs of infection. Let's see. So endometritis, your book talks about infection. Your book calls infection a temp of a greater than 100.4 on 2 separate days.
My lady had 103 today.
Labor? Mm-hmm. So they're gonna watch her carefully.
Mm-hmm.
So we may end up
Gave her
with,
ampicillin.
yeah, so they're already treating it.
Yep.
If it gets real high on the actual floor, right, real life, they start to spike a fever, we're gonna treat it right away. Your book says greater than 100.4 on 2 separate days. So we have real life and we have what our book says. What increases our chance of endometritis or that infection?
Not
Think
changing
about-
pads.
Yeah, but think about what is happening in the labor process. What would make it more likely that we're gonna be infected? Or ruptured,
Yep.
yes, ruptured, prolonged rupture is gonna be one of the things. Super frequent vaginal exams, so checking somebody's cervix over and over and over and over because they're in labor for days and days and days. Every time we check somebody, we're introducing the bacteria from the vagina into the cervix, goes into the uterus. Usually talk about getting rubella postpartum. So rubella is a live vaccine. You guys learned about that in peds, right? So we don't want to give a mom a live vaccine during pregnancy. The only time we can guarantee she is not pregnant is before she leaves the hospital. By the time she comes back to her 6-week visit, she can very well be pregnant.
Yep.
We see that fairly frequently. 6-week visit, already pregnant. So don't want to count on that. So immediately postpartum, before they go home, they will get the rubella. You will also see them get Rogan. When do we get Rogan?
If they're O negative.
If mom is Rh negative and baby is, it's just Rh, doesn't matter, A, O, B, doesn't matter. Positive.
Positive.
Yes, so negative mom, positive baby is the only time that they get Rogan postpartum. Everybody who's negative gets it at 28 weeks, because even if we know dad's blood type, we can't guarantee that that is the dad. Even if the mom is like, I'm 100% positive. We as medical professionals cannot
Don't
guarantee
know.
that.
Yep.
Definitely had it 100% sure it is one father, and then the baby came out and it's definitely not that father. You can always tell by the scrotum color. Otherwise, melanin is later developed,
Yeah.
but scrotum is always a telltale. So
I'm sure that's awkward.
it is, because nobody in the room realizes it. They're all like, oh, he looks just like you. He in fact does not. But you can't say anything,
Yeah.
right? But so everybody gets it at 28 weeks. And there is the rare instance that both parents are Rh negative and there's like some way that baby can still be positive. Like I've seen it one time in the 15 years I've been doing OB, and it was a huge deal because the dad was negative, the mom was negative, and the baby is positive, and the mom is like, I did not do anything, I swear, the dad's mad, everybody is like on edge. And then like the neonatologist was like, let's do some blood work. Turns out it can happen. It's just super, super rare. We never hear about it. But point is, Rh negative mom, Rh positive baby is the only time we will give Rogan postpartum. So if your baby's negative, then you don't have to get it. Saves you an injection. You'll also see them get Tdap for what? What is the big thing in the Tdap that we want new moms to have? Pertussis. P and pertussis. So if they have not had it in the last few years, really every pregnancy, we recommend mom gets it during pregnancy at about 28 weeks is when they do all the injections. But if they didn't get it during pregnancy, the nice thing if they get it during pregnancy, whatever mom gets, baby gets, so baby gets some protection. But if they didn't get it during pregnancy, we encourage them, especially now, this time of the year, whooping cough is more prevalent, so we're gonna encourage them, hey, do you wanna get the Tdap before you leave? So those are the big vaccines / injections we give. Other big thing that your objectives talked about is thromboembolic disorders. So what are we concerned about with moms who just had a baby in terms of thromboembolic disorders? So think,
Getting a clot
yes, where?
in the leg or lungs.
Yes. So our DVTs and our pulmonary embolism are big. So how are we going to prevent it?
Pillows under calves.
Yes, but not under the knees,
Under the
right?
knees.
Under the knees, under the heels, it's going to pull it. So we're just going to cause it. What else?
Ambulation.
Ambulation. Get them up and moving as soon as we can. It's not going to be an hour post C-section because they will not have feeling yet, right? Takes a few hours to even be able to wiggle their toes. You guys have seen post C-section. And let's see. You guys have seen the SCDs on our post C-section patients. We really should be using them for all labor patients too, because they're in bed for an extended period of time when they get the epidural. We don't tend to. We try to just move them side to side, get them up, off their back, but really we should be doing it on every labor patient. They just get really messy if we do. But if you're having a patient who maybe is like a 2 or 3 day induction where they've done Cytotec, they've done Cervidil, they've done PIT, okay, those patients really need to have those SCDs. Or if they're on magnesium sulfate, all patients on MAG should also be having SCDs because our MAG sulfate patients do not get out of bed. Unfortunately for them, they are not allowed up. Partly because we don't want them to seize, right? But partly because it makes them feel really crappy. So we get them up, they get dizzy, they pass out, now we have a whole fall in our hands too. So SCDs, early ambulation, you will see also that on our larger patients who have a section, they start Lovenox as well, 24 hours after. And signs of a DVT are the same as they are on any adult patient, right? Redness, swelling, tenderness. Trying to think. Normal for moms to increase white blood count post-delivery. That's normal, so that doesn't necessarily mean it's infection. That's just part of delivery. I think this week you guys will probably talk about baby blues, so we can just talk about that. Any questions about anything you guys want to cover more of, or?
What were the stages of lochia?
So rubra, serosa, and oh my gosh, wait. Of course, the term is escaping my brain. Oh my gosh, turns white. What's it called? Alba, ALBA.
Rubra was like the reddish color.
Mm-hmm. And then there's serosa is like a pinkish brownish color, and then it turns into a white color. And if we have started to turn into that pinkish brown white, and then all of a sudden we turn to red, that's a reason to come back in, because we're thinking retained placenta. Kimberly, you're going a little cross-eyed. No, you're fine. It's
Did you
not
work
your
last
fault. You worked
Did you work
last night.
No, I'm on evenings now.
Oh, good. No, you're fine. I'm just teasing you. You're fine. It does not bother me. I think that's mostly postpartum stuff. And have you guys seen the peri-bottle rinse of the perineum? So we know we use warm soapy water and just pat, don't rub. Yeah, I think you guys will talk about baby blues and postpartum depression this week, so we can talk about that next week. Making sure we're using the incentive spirometer like we would after each surgery, after a C-section. And we know afterbirth pains increase with every pregnancy and with breastfeeding. 1, totally fine. 2, by 3, I was like curling my toes when they were breastfeeding. It's like, oh my God. Okay, well, we can talk more next week. You guys want to?
Thank you.
Yes. Yeah, so before the exam, we'll still need to go back and do the first few chapters.